Thank you so much, Dr. Blandford. Colleagues, we are now moving into the presentation led by the HSRC together with the CDC team. And I'm going to ask Professor Sizulu Moyo to then join us online. While she does that, we can quickly just if IT can confirm if some of the responses are ready, okay, to the questions that we have asked regarding your expectation of the day and also the reflection on the gallery that Dr. Blandford was speaking to. So the first question was around your expectation, and we see that people spoke about wanting to learn more about the findings, looking at the lessons that learned, just interest in the feedback that they are going to get around what is happening in their province. Also trying to make sense of the data that is going to be presented. They want to have an insight into the survey. They want to be just part of the engagements or the dialogue and also enhance their knowledge. Hope it's around HIV and the prevalence and some of the key drivers here. Media coverage, reality check, I'm not sure what that would relate to, but also just to get feedback, share and discuss some of the findings. If we can just quickly go to the second question around how did the image gallery make you feel? Some of the colleagues were able to go there, but we also displayed it online for those that could not access that space. Some of the reflections include being proud of how far we came. We have a lot of work to do, growth that has taken place. Where is it? Nostalgia, mixed emotion. Okay, I see there are colleagues that are also attending online, and thank you for participating in this memory lane and learning. Emotional but excited as well, and thankful, optimistic, and passionate, emotional. If we can just go to the third question around name one thing that makes you unique. I believe in giving my best, determination, born free, tenacity, my faith in God being His, kindness and understanding, Filipino. Okay, no, that is fine. Okay, so there's one person that has run 10 comrades marathons. Congratulations to you. That's good. So one person said their fingerprints make them unique. The background, pianists being uniqueness, being hardworking, baby toenail. So there's a lot, I think, as we engage in the small groups, there's a lot that we can also learn about each other, and we'll see if we actually have things that we share in common. Perhaps there are other people that have also run marathons. There are also some of the tips that can be shared on how to prepare or start that journey of resilience as well, because it takes a lot. So colleagues, I'm now going to welcome the colleagues from HSRC and CDC to share the findings, and perhaps those that are a bit at the back then can come in front so that they can immediately get into the stage as well. Thank you, Professor Sizulu Moyo.
Thank you, Dr. Makola. Just want to check that this is it working? I can't advance the slides. Okay, there we go. Okay, just go back. Okay, thank you very much, Dr. Makola, and thank you to everybody for being here today. First of all, Happy Heritage Month. I hope that we are all enjoying Heritage Month. And on that note, I also just want to say that it's been 20 years that the HSRC has been doing this, so it's also part of our heritage in a way. Secondly, before I start, I also want to say that as we're going to be discussing this data today and thinking about what the findings mean, it's also auspicious that at the City ICC, there's actually a conference that is looking at epidemiology. So what we are going to be presenting here, which is more of a description, in the keynote address, they say that descriptive epidemiology is not a dirty word, it's very important. So you can look to understand what you see, and then you can go deep into other aspects. So this data is very important, and it's also grounded in science in terms of being robust in what it means for the country and also for the Western Cape. So I think, as has been said, the findings, the national findings were presented, first of all, in November last year, and then at the IAS, and then we've been going around the country speaking at provincial level, because what is known now is that we do need to take the data down to the local level for us to actually have the impact. The national picture is great, but now we need to find out where are the pockets and what is happening at a local level, so that we can then have those interventions that are specific to the particular areas that we are looking at. So just to give you an overview of the presentation, I'll start a little bit talking about the background of the SABSSM survey series. I think Dr. Blanford has already said a lot about that. And then I'll speak about the main objectives of the survey, looking at the methods. So methodology is very important so that we can understand that our results are robust and they are correct and accurate. Then we'll then go on to the provincial results. We'll talk a little bit just to contrast with what was found at a national level. We'll look at antiretroviral treatment, we'll look at viral load suppression, and then important, the 95, 95, 95 targets. So these are very critical in terms of us ending the HIV epidemic. So how are we doing as a province? We'll talk about that. And then with the team, we'll go and talk about the key drivers of the epidemic, and then we'll go and make some conclusions. So the story of SABSSM, and I did say to Bridget, some of you may know her, she is one of those people who was there at the beginning when, as Dr. Makola spoke about the gallery, when it was not fashionable to do this type of work, when it was not fashionable to talk about this. So we're very honored to have you here with us today, Bridget, and we really, this work rests much on your shoulders. Thank you. So we started in 2002, as I've given you the history. That was the first one that was done. And then 2005, 2008, 2012, 2017, and now it's 2022. Okay, that wasn't me. And so the survey really, over time, has been and continues to be a source of information for looking at the progress of implementation of the NSP. We know that in South Africa, really our focus when we're dealing with HIV, dealing with TB, we're guided by the NSP. And the NSP really relies a lot on the data that comes from this study. We also know that other international agencies also use this data, and other local partners also use the data. So from 2022, as you can imagine the journey, up until now, the survey has expanded in scope. For one, the sample size has become larger. Also, the biomarkers that we look at, we've expanded those. In 2002, there was no 95, 95, 95. There was no 90, 90, 90. Those days, art was not even something that we could speak about at a population level. But obviously, now we have to look at that because we have those interventions and we have those treatments that are available. Also, in terms of who do we look at, in 2002, I remember that they were taking only a certain number of people in the household. For example, they would categorize according to the age groups, maybe take one child, maybe take one adolescent, maybe take one adult. But now it's everybody. So when we say the results are generalizable and applicable to the country, it's really reflective of that. It's a big sample size, and we're taking people of all ages. Also, another thing, in South Africa, we take people from birth to whatever age. In other countries, I know that some of the HIV surveys focus on 15 years and older. So we are very fortunate that we can also look at pediatric data for the country. Oh, I just didn't want to miss this picture. I need to go back. So these are the founders of the survey. I think you can see, I think Bridget is there, if I'm not mistaken. But you can see the former President Nelson Mandela, and also just to highlight people like Professor Olive Shisana, who really set the groundwork for us to be able to get this type of work. So I think we should also remember that as part of the heritage and the history of this study. So what are the objectives of the survey? So the objectives are to estimate at national, provincial, and district levels, not all the 52 districts in the country, but PEPFAR and NDOH priority districts, and we can talk about those. So at those levels, we look at HIV prevalence, adults and children, as I've already said. We look at exposure to antiretroviral drugs. We look at viral suppression in those who are living with HIV. And then we also look at incidence, because we know that, new infections are what really drive HIV. But unfortunately, the nature of the science when we do cross-sectional studies is that we can only really have a robust estimate at a national level. It's very difficult to bring that down to a provincial level, because then the statistics don't become very stable. So in terms of the geographic scope, it's a national survey. All provinces are included. In terms of the districts, we had 27 PEPFAR priority districts and 6 national priority districts. These are the Department of Health priority districts. And in the Western Cape, that included the city of Cape Town. So when we talk about these districts, it's where we then have additional sampling, where we sample more people, and then we can present those results for that particular strata or for that particular area. Then in terms of the design, it's a cross-sectional population-based household survey. So we go to people's homes, and I think this is the strength of the survey. You can say people do access health services, but there are some people who don't go to the facilities. We know for many reasons. So we're able to reach those people in their homes and do the testing, so we can get the information from them. It's a multi-stage stratified cluster random sampling. And what is important about this is that the design and the methods have been validated in 5 previous surveys. Actually, this design, when it first started, I think by survey 3, it was actually exported to other African countries who also have to do this type of work when they want to measure their HIV burden. I've already said that we look at everybody living in the country. All members of the households are invited to participate. And in this particular round, the 2022 survey, we started collecting data in January 2022 and ended in April 2023. And our sample size for the Western Cape, we needed to reach a number of about 5,200 people for us to be able to compute a robust result. Okay, I don't know what happened there. Okay, so this is the map of the Western Cape province. And what we can see, the red dots are showing you the small area layers. These are that were sampled. These are the geographic areas that were selected to be part of the survey sample. And as I've mentioned, that the city of Cape Town, we had additional sampling there. So you can see that the red dots are clustering there in that area where the Western Cape is presented. I mean, the city of Cape Town is presented. So in terms of how we then collect the data, we've got 2 types of questionnaires. We've got a household questionnaire, which we use to record the household listing, understand who is in the household, and then look at other household level information. We're not going to present all the household level information, but I think there's no denying that HIV is very linked to many of the family or social circumstances that we live in. So that information becomes very important for later analysis. Not going to present it today, but we do look at it and we can share that, and some of the publications over the years have also described that. Then we've got individual level questionnaires. We've got questionnaires for children 0 to 11 that are administered to the parent or the guardian. And then for the adolescents, 12 to 14 years, we ask them, they respond themselves, and then everybody 15 years and older, we then also interview them individually. Okay, so that was the questionnaire. And then obviously we speak about prevalence, we speak about incidence, we speak about art. We need to test that. We collect blood by finger prick, and we make these dry blood spots. This is quite an ingenious method that is in the HIV space, so that we can, manage to collect lots of samples to be tested. So we do finger pricks for people who are 2 years and older, and then in infants, we then do the heel prick. And you can see there in the picture, we prick the finger, and then we put the, okay, I don't think this works. And then we collect the blood sample into this microtainer here. And then we then spot it. We create 10 spots, which are then analyzed in the lab for the different biomarkers that we look at. And then in terms of the biomarkers themselves, I'm trying to see if this thing is a pointer. Is this a pointer? It doesn't point. Okay. All right. So from the dry blood spot, we then do the HIV antibody testing, and our testing is robust. So we actually use 2 4th-generation assays, and then we have a confirmatory test. So when we say it's an HIV positive, it's definitely HIV positive. It's been confirmed. And then for children, obviously we know because of maternal antibodies, we need to use a different type of test. So we use a NET, so we can confirm that these are not maternal antibodies. So everybody who then has an HIV positive result, then there's additional testing that we then undertake. We do assays to look at HIV incidence. So we run the leg assay, and then we put that through an algorithm that we call the Rita Plus, so that we can then compute what are the new infections in the country. So annualized number of infections over a year in the country, and I think those were presented at IAS, those numbers are there. And then we also look at antiretroviral exposures, and this is actually done here in Cape Town. It's done at UCT Pharmacology. So we work a lot with the pharmacology department. We speak to them, they advise us which are the best drugs that we can look at. We can't test for all the drugs, but there are key drugs that are the backbone drugs in the ART strategy, so we need to test those, and we always are guided by them. We also look at viral load, obviously for viral load suppression, and we use the Abbott HIV system. And something that we added in 2017 was HIV drug resistance. And I think this is quite important. As more and more people are on ART, and as people stay longer on ART, the issue of resistance is important. And there are methodologies to do this. But what this survey does is that it gives us that snapshot around everybody, even those who are not going to facilities, because otherwise the recommended methodologies are focused on those attending at facility level. So now going to the results, starting first with the results, Dr. Blanchford did say thank you to those who opened their homes and allowed our study teams to be there. We had we had 1,271 visiting points, and you can see the definition of a visiting point there. It's a physical address or a dwelling where a household or a group of households can be found. It can be a house, it can be a shack, it can be a vacant stand or a hostel, so where people live basically. So about 1,300 were approached, and 1,260, which is 99%, were valid. Out of those that were valid, 86% completed a household interview. And of the eligible individuals, so we found 3,586 individuals who were eligible from the age of 0 upward. Over 90% were interviewed. And then we had 62% who gave us blood for HIV and additional testing. So the interview rate is great, but giving us that prick, that blood, which is so important, is something that we can do better. And hopefully in the deliberations today, if we come back for another round, we can learn also from colleagues how we can do better to improve that number. And then when we break it down by sex, out of the just over 1,000 eligible males, 15 years and older, we had 87% interviewed, and 60% gave us a blood sample. So men lagging behind, we need to do more. So also interested to hear around what people may think, how we can improve that. And then when it comes to females, 93% were interviewed, and then with 68% who gave us a blood sample. So in terms of the prevalence rate for the Western Cape, and we're also showing you the 27 data just to see how we've moved from 2017 to 2022. So the overall prevalence for HIV estimate for HIV prevalence for all ages in 2022 was 7.4%. So what does that mean? It means about 540,000 people living with HIV in the province. The HIV prevalence in 2017 was 8.6, so you see there's a drop from 8.6 to 7.4, and at that point we're estimating about 560,000 people, so about 20,000 reduction over that time period in terms of the actual count. And then when we look at it and compare with other provinces, the Western Cape is right at the end, shown in green. We can see 2017 was 8.6 and 2022 is 7.4. And just to give you the national picture, in 2017 it was 14% and in 2022 it was 12.7%. So generally we've just seen this decline across the board, across the provinces and also at national level. Just to say that we've not presented the confidence intervals here, but when the report is done, the confidence intervals will be shown. And this is a graph that shows you the prevalence when we look at it by age bands. So we can see the pediatrics, from the pediatrics 0 to 14, right up to those who are 60 years and older. The blue line is 2017 and the orange line is 2022. So if we look at the blue line, you can see that it peaked in those who are 35 to 39 at 23.4%, meaning that in that age group, actually 1 in 5 people were living with HIV in the country at the time. In 2017, that's quite a lot. Yeah, but also I just want to point out the pediatrics, 0 to 14. In 2017, it was 2.9. Now, coming to 2022, the overall picture is that we are seeing that there is a shift. It's not that prominent for the Western Cape, but generally we're seeing a shift that people who have got HIV are mainly older, seeing more older people living with HIV, meaning that the antiretrovirals are working, the interventions have got impact, people are surviving into later stages of life, and the peak is not as high as it was in 2017. It peaked at 23.4%, but now you can see 45 to 49 is 11.8, and 55 to 59 is 9.7, 30 to 34 is 12.8. So the peaks are not as high as it was before. But I think I do want to point out that we need to think about the children. We can see that in 2022, we're finding that is 4.3% in those who are 0 to 14, and also 15 to 19, prevalence is 6.7. So we need to think about that. And I think in the pediatrics, definitely the issues around survival, of course, but also new infections, we need to be thinking about that. And then this is just stratifying it by sex so that we can see who is most affected. So females, 9%, and males, 5.6%. We know that in South Africa, really, people who bear the burden of HIV are women, and this is not different in the Western Cape. And then when we break it down by age, according to sex, 0 to 14, females is 3.3, in males is 5.1. We can see the difference there between males and females in the younger age groups. 15 to 24, 3.9 in females and 5.5 in males. And we can see 25 to 49, 14.6 in females. We know that's, we can even look at it from 25 to 49, but also 15 to 49, our reproductive age group. But that 25 to 49, you can see the difference between females and males. And then when we look at it by where people live, the right side of the slide, in the urban areas, females 9.1% and males are 5.3%. In the rural areas, the farms and the farm areas, 8.2% in females and 8.7% in males. And then within Cape Town, where we oversampled, we can see that females almost 10% and males about half of that. So that's something that we can also discuss and think about what's happening there. Okay, so we've spoken about prevalence. Now, when we come to antiretroviral treatment, we can see the Western Cape also represented in green. In 2022, we had, that was 2017 is the top one, which was 54%. So this is population level. Just looking at people who are living with HIV, testing them for whether they've got any traces of the antiretroviral analytes, just over 50% of them were on antiretrovirals. But I think it's an improvement. In 2022, we can see that it's about 77%. It's not where we want it to be, but definitely it's a big jump over that time period. And then when we break it down by sex and by age, and I just want to point out that where you see the dashes, it means that our sample was not large enough for us to compute statistics that were robust. So it speaks also to participation. How do we get people to participate so that we can get robust numbers? We know that in the 0 to 14, we have HIV, as you saw from the previous graph that I showed you. But how do we then get the sample so that we can understand what is happening in terms of access to treatment and remaining on treatment for these particular age groups? So we can't break it down by sex in the younger ones, and even in the 15 to 24, an age group that we know is quite important nationally, but I also think provincially. Then 25 to 49, we had in females 77%. Males, we didn't have, the numbers were not large enough for us to compute a robust statistics. And then I'll just go to the 15 years and older. It's about 75% for both males and females. And then when we look at it by locality type, in terms of those in the urban areas, it's also just about 74% for males and females, so the same. And then in the city of Cape Town, we had 81% for females, but for males, our sample was not large enough for us to compute a robust estimate. And then from prevalence to art, now we talk about viral load. The Western Cape is also represented in green. We can see that in 2017, it was about 55% of people who were living with HIV who were virally suppressed. This is at a population level, not the 95, 95, 95. And then in 2022, we've now gone up to 78%, so also an improvement, which is good news. And then we also break it down by stratified by age and sex. So if we look at, I'm just going to focus for 15 years and older, females, more of them are virally suppressed than males, 83%, and the males are about 71%. And then if we look at locality type, in the urban areas, it's the same for men and women. And city of Cape Town, not much difference between men and women in terms of viral suppression. Now, the 95, 95, 95 targets, I think I spoke about this at the beginning, that these are very critical. If we're going to end HIV, it's important that we hit these targets at a national level and also at provincial level. And we know the definitions that have been put forward by UNAIDS. So for the survey, we try as much as possible to be close to those definitions. And so the first 90, of course, is being aware or know their HIV status, and if tested positive in the survey. We also took those who reported themselves to be HIV positive. What we found in our study is that self-report and laboratory testing are very well correlated. So we can take the self-report to be accurate. Those who tested positive for antiretrovirals in the survey, so maybe for some reason they didn't self-report, and maybe there was something that happened with the sample. We don't have the antibody result, but if they tested positive for antiretrovirals, we know that then they are HIV positive. They would know that they're HIV positive for them to be on treatment. And then those who also self-reported as using antiretrovirals. For the second 95, which is the being on ART, we wanted those who tested positive for antiretrovirals in the survey and those who also self-reported that they were taking ART. And then viral suppression, we use a cutoff of 1,000, and this is what is generally used in surveillance. And also, I think, thankfully, or just to show that this is a robust cutoff, we know that U equals to U is defined on this cutoff of 1,000. So those are the definitions that we use for our 95, 95, 95. Okay, so now, overall for the Western Cape, from our survey, we found that about 86% were aware that they were living with HIV. Amongst those who were aware that they were living with HIV, 91% were on antiretrovirals and 92% were virally suppressed. So there's still some way to go in terms of awareness, still some way to go in terms of treatment, but what is encouraging is that it looks like when people are aware that they are living with HIV, they do get onto treatment. And then the 92% also some way to go to 95, but it looks like when people are aware that they're living with HIV, they get onto treatment, they do stay on treatment, and they become virally suppressed, which is something that is positive. When we stratify it by sex, when we look, this is now 15 years and older only. When we look at the first 95, for men, it's 79% were aware of their HIV status. About 98% were on ART, and then 93% were virally suppressed. For females, 88%, and then 88% again on ART, and 92% being virally suppressed. I think the message here is that we need to do more to get people to be aware of the HIV status. But once they are aware and they are on treatment, they tend to do relatively well. We still need to do some improvements, but we see those percentages being quite high. When we then look at it by age group, unfortunately, we can't talk about the 15 to 24, but we can talk about the 25 to 49. 86% were aware of their HIV status. And amongst those who were aware, 90% were on ART, and viral suppression was 92%. The reproductive age group, 15 to 49, it was 85 for the first 95, 86% actually, 85.5, and then 91% being on ART and 93% being virally suppressed. Now, we've got the results, obviously, for the city of Cape Town, which was the district where we oversampled. The first top part just gives you the overall for the Western Cape, but for the city of Cape Town itself, it was the first 95 is 90%, the second one is 92%, and the third one is 90%. So it's quite nice numbers. Obviously, it's not the 95, 95, 95. If we were talking about 90, 90, 90, we would have hit the targets, but 95, 95, 95, we can still do better. But I think it's encouraging. Now, obviously, the people who know their status, who are on ART, who are very suppressed, we do need to encourage them so that they stay on to ART. We know treatment fatigue is something that we need to think about, but there are these people who are not where we want them to be. Those who do not know their HIV status, those who know their HIV status but are not on treatment, those who are on treatment but they are not virally suppressed. So here, what we tried to look at, we wanted to look at the contribution by age group to the gaps in the 95-95 targets amongst people 15 years and older. So if we look at the percentage contribution, the first bar that you can see there, the percentage contribution to all people living with HIV, 25 to 49 is the largest contributor. 15 to 24 is about 10%, And then the 50 years and older, which I think is quite significant for this particular survey, that we've got this older generation of people who are living with HIV. It's about a quarter of the contribution. Now, when we look at it in terms of the contribution to all the people who are not aware of their HIV status in the province, the biggest proportion, I think it only follows, that is the 25 to 49. But you can see that the amongst the 15 to 24, we've got about 20%. That's the contribution of that group. So we need to do some work there. And in the older age groups, 50 years and older, it's about 23%. And then the percentage contribution to all people living with HIV who are aware but are not on treatment. So getting people onto treatment when they are living with HIV, the biggest gap is in those who are 25 to 49. So we need to work with that group. But in children also, 15 to 24, the adolescents, the young people, it's about 15%, and then about 20% for 50 years and older. And then in terms of viral suppression, about a third of the gap in the 95-95, the third 95 is from those who are 25 years and older. 11% the adolescents and young people, and then 22% in those who are 50 years and older. And I think this is where I hand over to my colleague, Dr. Vuyelwa, to come and speak about the drivers.
Good morning, colleagues. I will be taking you through the key drivers of the epidemic in the Western Cape, but we will be focusing mainly on the behavioral drivers. Starting with the sexual debut before the age of 15 years amongst youth aged 15 to 24 years. If we look at national level, we can see that in 2017, 13% of the youth reported that they engaged in sexual debut before the age of 15. And that has declined to 11.2% in 2022. If we look now in the Western Cape, which is the first green, we see that there is an increase from 2017 to 2022, from 14% to 16%. Okay, when we stratify this by sex, a higher proportion of males reported that they engaged in sexual debut before the age of 15 at 21.5%, compared to females at 11.3%. And in urban areas, we see that 15.8% reported sexual debut. And in the city of Cape Town, where we oversampled, 50.2% reported that they engaged in sexual debut before the age of 15 years. Moving on to multiple sexual partners in the last 12 months among people aged 15 and above. We see that at national level, those who engaged in multiple sexual partners, there has been actually a decline from 10% or more or less 11% in 2017 to about 9% in 2022. But when we look in the Western Cape, in the far end, we see a slight decline as well, from about 7.6 to 6.7 in 2022. So those are individuals who reported that they engaged in sexual partners. And then if we stratify that by sex, we see that a higher proportion of males reported that they engaged in multiple sexual partners at 8.9% compared to their female counterparts at 4.4%. And if we look in terms of age groups, a higher proportion of those in the age group 15 to 24 actually reported engaging in multiple sexual partners at 19%. And then when we look in terms of locality, those living in the urban areas, so 6.8% of them reported engaging in multiple sexual partners, while 5.4% from the rural, formal or farm areas reported engaging in multiple sexual partners. And looking at the city of Cape Town, 8.2% reported engaging in multiple sexual partners. Moving on to condom use, which is a concerning picture. At national, we see that there's a decline in terms of those who reported that they use condoms. In 2017, it was 39%. In 2022, it declined to about 32%. A similar pattern, or we observe a similar pattern for the Western Cape as well. And if we compare the Western Cape with other provinces, we're right at the end. In 2017, Western Cape was at 26.6 in terms of people using condoms. In 2022, that has declined to 22.1%. In terms of consistency of condom use with the most recent sexual partner, amongst those who are 15 years and above, if we look right here in the first column for the Western Cape, a very high percentage of people reported that they've never used condoms, at about 65%. And compare with only 13.4% who actually reported that they used condoms every time. If we look in terms of the city of Cape Town, once again, we observe a similar picture where 63.1% reported that they've never used condoms, while 14.4% reported that they've used condoms every time with their partner. Okay, I think that is where I'll hand over to my colleague, Mr. Molopo. Thank you.
Good morning, everyone, both in person and online. So I'll be taking you through, let's just see. Okay. I'll be taking you through self-reported circumcision among males aged 15 years and older. So looking at the national estimates, we went from 60% in 2017 to 63.7% in 2022. And a similar trend is observed for the Western Cape. We went from 52% to 50.9%. Actually, that is a decline. So a decline from 52 to 51%. Then looking at it by age group, we see that among those aged 25 to 34 years, 58% had the highest prevalence of or self-reported circumcision. And then the lowest was among those aged 15 to 24 years. And then by location, it was only, the lowest was in rural, formal, or farm areas, which was 27.3%. In the city of Cape Town, self-reported circumcision was highest among males aged 50 years and older. And this was also seen, the lowest was also seen among those aged 15 to 24 years. Okay. So self-reported circumcision type, so this is your medical circumcision and traditional circumcision. So nationally, medical circumcision was at 60% in 2022, and traditional circumcision was at 39.2% in 2022. In the Western Cape, medical circumcision was at 46.3% in 2022, and traditional circumcision was at 53.5% in 2022. Okay, then when we look at this by age groups, so among those aged 15 to 24 years, medical circumcision was at 41.9%, which was basically 42%, and then traditional circumcision was at 57.1%. But the highest in this, among the age group, was those aged 50 years and older, which was 60% for medical male circumcision, and then 40% for traditional circumcision. Then by location, medical male circumcision was highest among those residing in rural, formal or farm areas, which was at 50%. And then traditional circumcision was highest in urban areas, which was at 53.7%. And then looking at the city of Cape Town, medical male circumcision was at 46%, and then traditional circumcision was at 54%. Looking at awareness and uptake of pre-exposure prophylaxis, so PrEP, among people aged 15 years and older. Overall, in the Western Cape, 34% reported to have ever heard of PrEP, and 62% reported that they would take PrEP to prevent HIV. In the city of Cape Town, 37% reported to have ever heard of PrEP, and 66% reported that they would take PrEP to prevent HIV. HIV testing among people aged 15 years and older. So we'll start with females. So looking at the age groups 15 to 24, we see that 22 or 23% rather reported to have never tested among females. And then, but the highest proportion was mostly among those aged 50 years and older who reported to have never tested, which was 30%. And then among males, we see that those aged 15 to 24, 36% reported to have never tested. And then again, the highest proportion was also among those aged 50 years and older who reported to have never tested, which is about 36%. Overall, for the 15 to 24, 25 to 49, we see there's a high proportion of people who tested in the past 3 years and received their results for both males and females. Okay, so I'll be stopping here and passing over to Dr. Pelagia.
Good morning, everyone, and all protocol observed. My name is Pelagia Mranganti from CDC. I'll be taking you through the few remaining slides. So in conclusion, what did we see? We saw that Western Cape had the lowest HIV prevalence nationally at 7.4%, and we saw a downward shift in HIV epidemic curve, which could signal a stabilizing epidemic. However, there are still disparities in the burden of HIV, with HIV prevalence approximately 2.5-fold higher among females as compared to males aged 25 to 49 years. Antiretroviral treatment coverage and viral load suppression was the second lowest nationally in 2022, and work remains to reach the 95-95-95 targets. And with circumcision, we saw that circumcision among males aged 15 to 49 years was at 50.9%, which remains below the national target. And 46.3% of the circumcised males reported medical circumcision. And knowledge of PrEP was at 33.5%, and current use of PrEP was 1%, which was universally low. However, willingness to take PrEP was high at 61.9%. Sorry for the direction. So with this, what are the actions that can be considered by the different stakeholders? A long-term strategy to care for individuals in an HIV epidemic, in an aging HIV epidemic, with heightened focus on campaigns such as U=U and other strategies to promote uptake and sustained use of antiretroviral treatment. And also addressing health inequalities and combining prevention strategies to address specific HIV prevalence and treatment rates of concern in the province. And enhancing prevention efforts that target groups disproportionately affected by the key drivers of HIV infections such as women and young people, as well as focused efforts to increase coverage of male circumcision and continue to engage with traditional houses, leadership, and practitioners to ensure maximum health benefits among circumcised men. As so most men reported traditional circumcision. And finally, enhancing accurate public awareness of effective HIV prevention measures, including regular HIV testing, condom use, and pre-exposure prophylaxis. So with this, I would like to thank the field workers who spent 15 months in the field collecting the data that was just presented to us. Without them, this wouldn't have been possible. Thank you.
Thank you, South Africa.
Thank you. So this work was a collaboration among various partners, and there was a consortium of partners led by the HSRC, and this included U.S. Centers for Disease Control and Prevention, South African Medical Research Council, National Institute for Communicable Diseases, University of Cape Town, National Department of Health, South African National AIDS Council, United Nations Children's Fund, United States Agency for International Development. And the funding source for this survey was the U.S. President's Emergency Plan for AIDS Relief, PEPFAR, through CDC, and to whom we are very grateful. And this work was also possible because there were a number of contributors who contributed from the development of the survey, implementation, and the reporting stage. Thank you.
Thank you so much, Dr. Pelagia Murangadi, Dr. Vuyelwa Mehle-Makhulu, Mr. Lisiba Malopa, and Professor Sizulu Moyo for the presentation. We will make the presentation available. I've noted colleagues taking pictures and trying to write as fast as they could some of the numbers as they were read. So we'll make it available for you so that you can also share with your colleagues. I'm sure there are a few questions that you also have. So we are going to move into the tables. Just to note that the colleagues that are from HSRC and CDC that are sitting in the tables have prepared this presentation, have also worked on some of the surveys. Well, so whatever questions that you have, they'll be able to address them in the table as well. So we will now from 11:15, we will start the discussions following the questions that will also be displayed here. Each facilitator would indicate the questions that are allocated to you. And then we would then meet again at 12 o'clock for a feedback session, about 30 minutes. We'll just see how the time goes before we go into lunch at 12:30. And as we've mentioned earlier on, for tea break, we'll just allow colleagues to move into by different tables, just so that we don't spend a lot of time queuing. So I think that's it. So colleagues that are online, if you can meet or come back at 12 o'clock for a brief feedback from the few tables, and then we'll break for lunch, and then come back again at 1:30 to then finalize or finish off the feedback sessions as well, and then complete the rest of the program. Okay, thank you.
I think not everybody can hear me yet. If you can hear me, just raise your hand. Okay, I think there's most people can hear me now. Colleagues, we are going to move to the part of our program where we will get feedback from the different groups. I know the groups still would like to, continue with the dialogues, but we would like to manage the time that was allocated for this. And I think, as Dr. John said earlier this morning, this is only the start of many conversations that we will have. So we're going to start with question 1, and we would like to ask the person who would present from that group to just indicate the name and the organization that you're from, and then we will ask the first group that will go. I think there's 3 groups that covered question 1, just to share the question with everybody. And how we will do this, we will give 5 minutes per group feedback, and then afterwards, while you listen to the group, if there's really a burning question or more question of clarification, or an addition, that there will be some time for you to add that. So we will look at question 1, which really covers what are the lessons learned in the province. And then we are asking the presenters to please rise by standing, using the mic, so that the camera can also pick up on your feedback, and we can also still keep everyone online also on board. So we'll start with question 1. Can we just get an indication which tables dealt with question 1? Okay, so we've got the table in front, the one in the middle, and the one in the side. So let's start with the table in front to provide us with feedback on question 1. There was 3 sub-questions that was discussed, and your 5 minutes will start now.
Hi, good afternoon, colleagues. So I'm Nosi Kalawe. I'm working in Northern Tigerberg substructure, and I have an honor of working with Group 1, who are sitting here in this round table. So we looked at the aging epidemic implications. Yeah. So we said with the people, older people getting staying on with HIV, we need to look at the fourth 95, zoom in more with the fourth 95, because quality of care is important also for them. So when they come for treating their chronic diseases, we should actually be testing and treating them intentionally. And then secondly, we should look also at their resistance, because they're staying on and some come out of treatment and come back. So we must make sure that we look at their resistance. There's already a study that is going on. Vanessa will talk more about that, where they look at the resistance also on people. And then we also have to look at intersectoral approach, where with older generation, there's a lot of social determinants of health that are affecting them, and they also get depressed. As you know, mental health is an issue nowadays, so we need to make sure that we're not only working here in silo, we also work with other people like DSD to manage the aging epidemic. And then one thing that came out from the IAS, Bridget, IAS conference was that the elderly people are actually having sex at least minimum 3 times a week. So don't think that the older they are not having sex. So it was actually research that was done. And we also assume that they are wise, they would use condoms, and most of them were not using condoms. So, and our focus mostly, especially here in Western Cape, I can only talk about Western Cape, our focus for differentiated models of care, it's more in the younger people. So I am urging, and it's a call for all of you as you go back today, to go back to your substructures, and we start opening art clubs for 60 plus years, and we call them WISE clubs, because they also need focus when it comes to art. And then we need to be culturally sensitive so that we make sure that we keep them, the remaining in care, and we keep those viral loads that were suppressed, impressive results that we were told today. And then one last thing, we tend to focus in family planning, SRH, when it comes to PrEP. We need, in those chronic clubs for diabetes and HIV, we need also to test, and if they are negative, we need to also offer them PrEP. Any other from my group? Did I forget any other point on? Okay, thank you. Second question also. Oh, yes. Okay. Okay. The second question was, where are we when it comes to HIV? So the education is happening, but we need to make sure that we get to where the patients are. So communication is happening from our departments in Western Cape by comms, but comms need to also focus more on using social media. Not only comms, our NPOs also need to use social media. The TikTok, it's making noise for us. People are not sleeping on TikTok. We need to also be there and TikTok about 95, 95, 95, 95, 495. And then health promoters. We already have health promoters that are going out there and giving messaging to the community. And most of the time, they are talking about diabetes and hypertension, and they're doing an excellent job. We need to just strengthen our health promoters when it comes to also talking about HIV, because HIV has become a chronic disease, as you see, aging population. So they must talk also about preventative strategies of HIV and treatment. And then we need more campaigns on You is Equal to You, not only in facilities, but also in community. And then we were saying, what happened to the billboards? We used to have lots of billboards. As we are driving, you would see messaging about HIV. Are we assuming, or our government is assuming, that all people know about HIV? So we said, actually no, because there are people who are growing up, and you could see the young people when it comes to data that are growing up and they don't know about HIV. So we need to keep those billboards, because those billboards, they start conversation. People come maybe to at home and start asking questions. So bring billboards back. And then adverts, people tend to love Generations and what are the other sitcoms? Generations, Scandal, and so adverts before the scandal. Give more adverts on TV for those who are still watching TV, which are about HIV prevention and also HIV treatment. Thank you. Oh, okay. Last one, third one is strategy for men. Okay, so men, think of a taxi driver. Men have no time because they must work and work and work. So we are saying, let's use more Insti. Does everyone know about Insti? Who knows about Insti? Insti. It's a 1-minute test. So HIV self-screening is divided into two. There's Aura Quick and there's an Insti. The Insti is the 1-minute test. So let's use more Insti for men, because they don't have time. They want to rush to work. Okay. But they do have time for sex, but they don't have. Okay. And then, but also we must be conscious of other men who are afraid also of needles. So there is still space for Aura Quick. And then make it friendly for men. If you think about Mina, continue with those audio messagings while they are sitting to be listening to audio messagings about HIV, making them aware of HIV and also the prevention and the treatment. And then PSH is gone. And I cry because PSH was doing a lot of work when it comes to men. They would call men to come and compete. There would be two groups competing in sports like soccer. And then while they are doing, they are actually playing soccer, they would also incentivize them and say, the people, after they finish, the group between the two that are competing, that tests the most, they will get some incentive. And it used to be a nice prize for the group. And I'm telling you, I was once in that campaign and 80% of the men tested at that time. Now, I don't know, maybe we need another type of PSH to come back, NPO. So NPOs are very useful. We must use them. Thank you. And we want Dreams 2.0, Dreams now for men, not only for women. Thank you.
Thank you so much. We're moving to the next group for the feedback. Same question. To add.
Good morning, everyone. My name is Harry Hausler. I'm the CEO of TB HIV Care, and I'll be representing our group, Group 4. We actually went through most of the questions, but I'll just try and focus on the first one. So I think it's really encouraging the results in terms of the 95s for the province, that it's 85 or 86%, 91%, 92%. But the breakdown when you look at men is concerning, because only 79% of men know their status. So there's a huge gap there that has to be addressed. Interestingly, once they know their status, they're more likely than women to initiate antiretroviral treatment, and there's reasonable viral suppression for those on treatment. But we do need to increase access to HIV testing, make it easy for people to get tested where they want to. And one of the suggestions that came from the group is HIV self-screening becoming much more available at community level through the community-based services. Community health workers now increasingly are being trained on HIV counseling and testing. They're going anyway door to door, so they could provide HIV self-screening tests to people in their households. And then also where men congregate, at taxi ranks or around shebeens or what we're at in workplaces. Clearly we need to make HIV testing services more available. People are living longer now with HIV, so that's really encouraging as we heard. But there's a big concern in the children and adolescents, and the 0-14 to be up to 4% is a red flag. We're wondering whether there's some kind of a decrease in the quality or consistency of the prevention of mother-to-child transmission program, because some of that may be a vertical transmission, so that needs to be focused on a little bit better. But then there also may be early sexual debut in those closer to 14 years of age. But I think there was a lot of discussion. We do have a representative from the Department of Basic Education with us just about how do we reach youth and where they are. And we know you spend a lot of time in schools, but there's always been this big barrier to be able to access school-going children. There is a comprehensive sexuality education program. Is that integrating U equals U messaging? It seems it's not. So I think that curriculum has to be looked at, but also more intentionally making the health services available to school-going children. Often school governing bodies can be a barrier, so there was a suggestion that we bring school governing bodies together to sensitize them perhaps about some of these results, the concerns about low condom use, the importance of testing, the importance for people who are sexually active to access pre-exposure prophylaxis, and if people are testing positive, the U equals U messaging. So that kind of integration between school services and health services. Now we had an example of 60,000 students having gone through CSE and only 300 being referred to the community prep services in Cape Town. So that has to change completely. And I think the scale up of prep, it was noted that it is available in family planning and STI services, but it has to be fully integrated into those services where people who are already looking for contraception or having issues with STIs have access to PrEP. And then also there was it was noted that condoms seem to be less accessible. So a more concerted effort to make sure all the condom containers are full, and that school-going children also have access to condoms, but that they're easily accessible and they're well supplied and stocked. And U equals U is such a critical message, and we have had a provincial launch with the Premier and the Minister of Health. But what has happened since then? It hasn't really, it doesn't seem like it's been fully scaled up and integrated in the messaging, both in the CSE and across health facilities, so that at the first moment that somebody goes through counseling and testing, they're already told about this, so that they know when they test positive that if they get on treatment and stay on treatment and get virally suppressed, they'll live a long and happy life and they won't transmit to their sexual partners. So I think those were the key recommendations from the group, unless there's somebody who would like to add from my group. No? Okay, thank you.
Thank you so much. I think if I remember, this was our third group.
Hi everyone, I'm Jessica Boyson from Civil Society. I'm the provincial chairperson for the research sector, sorry. But I'm also from an organization called Advocates for Prevention of HIV in Africa, APA for short. So I think both of our groups gave us important information. So basically what I'm gonna do is just add in where they didn't. Our implications for our shifting patterns of the HIV prevalence. We have that we need to go to spaces where older people are working, where they are active. Our colleague at the first table mentioned that we need to go to the gym clubs, the sports clubs where the older females are at, and actually go and do testing over there. Go to our old age homes, go to places and facilities where they are active in order to give them HIV treatment, HIV access, and prevention methods. I think the reason why that group has increased so much is also because once they go for HIV testing and once they're on treatment, once their viral load is down, we kind of look away from them and we kind of look at our focus target market. And I think that's why they have been growing percentage-wise as to why we're not looking at them. Question number 2, where do we learn about HIV? We learn about HIV at our NPO involvement, especially on schools, especially in our communities. We learn about HIV at our door-to-door outreaches, in our clinics, schools. And I think our media is also limited and it needs to be improved. When we talk about TikTok, when we talk about Instagram, we're talking about specific content and better content creation to adjust our target market so that they can actually find it interesting to actually want to come to the facilities and learn and see what is happening there. And then in terms of question number 3, in terms of HIV prevention strategies and how have they been successful amongst men, we think it has been successful. If we look at oral PrEP and we look at VMMC, the increase on percentage of men actually taking a look at it and actually doing it is actually quite high. And I feel like we shouldn't be looking away from that. We should be looking forward and how we can improve this and how we can better alert men to want to be getting themselves tested. Thank you.
Thank you very much to all 3 groups. We are now going to invite, if there's anybody in the room that needs to raise a question of clarification, to please do so. Was it all clear? No acronyms we use that we don't all know. Dr. Nosi, do you want to share? There was one acronym you used. Partners in sexual health, just for those in. Can we pass the mic maybe just forward? And then were there any additions? I also see a hand there. Just pass the mic to the second table on my right. Please go ahead.
Oh. All right. Maybe on point number 2B. Learning about HIV. I do think that we need to find a way to engage more with schools. I'm saying this for 2 reasons. There are learners that are in primary and high schools, and there are colleges and higher learning, other institutions. But I do think in terms of preparing our next generation for HIV-free, we do need to think about how do we engage both genders or all genders in the HIV, in schools within the HIV, particularly using the life orientation subject. Part of what we are missing is because the schools are busy and we don't want to interrupt, but we also want schools to be contributing to HIV response in South Africa. So in doing that, we had a conversation that I'm not getting into in this table, but I do think that the departments need to be talking to each other and find better solutions for young ones that are at school so that the HIV goes down in that age. And also clinics need to talk to these schools to see what are the projects that can be helping in contributing. Thank you.
Thank you so much. So I'm going to give Yolanda the last comment before we will then break for lunch. A small comment at the same table. Thank you, colleagues.
Okay, thanks for the opportunity. For us, I think one of the discussions we had was pertaining to VMMC, especially in the Western Cape. I'm not sure in other provinces. The target age is usually 18 and above. Now, if our younger boys are the ones who have a higher increased prevalence, they use condoms less, they are getting active in sex at younger ages, isn't there perhaps an opportunity to advocate for VMMC at younger ages? We might not win the traditional battle conversations much quicker, but I think for the medical we could.
Yes.
Because then we'll prevent them before they get HIV positive.
Thank you for your input, Yolanda.
Thank you. Just a short addition to the group. I think one of the things that we also noted for the strategies of improvement and what we've learned, the men's health clinics definitely work. We've noticed, the men love going to our men's health clinics in the various areas, and I think that is something we have met before, we've discussed it before, but I think as a province we need to maybe just sit and see how we can strengthen that more to reach a larger group of men so that we can actually reach that group also between 25 and 49. I think we will make a huge impact. And I think somebody that nobody mentioned, I think, is the condoms. What's happening to our condoms? I think going out of this room today, we really need to go back and check what is happening to our condoms, because obviously we thought clients are using it, but today's evidence is showing. So I think definitely the men's health, and I think with our partner support, we can definitely strengthen, making the men's health clinics available, maybe in our own clinics and our own setting, and making it attractive. And I think what you said, also reaching the men, because men don't want to wait, men don't want boring, they want the social media, they want the things out there that she's already mentioned, but I think it is definitely something that we can strengthen with the partners in the room. Thank you.
Thank you so much. Let's give the three groups a round of applause. We are now going to break for lunch, and I'm going to ask my director of the program just to direct us where we will get lunch, and then if we can be back here by 1:15, it gives us 45 minutes, and then when we reconvene we will start with question number 2. I think there's 2 groups that covered question number 2, and then also we will go to question number 3 and 4. So colleagues, if we do the same what we did just now, manage the time that we try and stick to 5 minutes per group, we can keep to the promise in terms of our time. Okay, so there's somebody outside that will direct us. So please do enjoy lunch and keep on networking, keep on connecting with one another. Thanks. Much, colleagues. So I was about to say, if you can hear me, please raise your hand. Thank you so much. Colleagues, we're going to reconvene and move to question 2, 3, and 4. So we're going to try and spend 15 minutes per question. So can I just get an indication who worked on question 2? There should be 2 groups. I know the group that I was part of. So let's start with the group at the back, and then we'll move to the group in front. I think it's that one. Yes. And then just for all of us to be on the same page, that question 2 dealt with what HIV messaging is critical to communicate and to whom, and there was also sub-questions in that question. So over to the group there at the back. Your 5 minutes will start now.
because the person who was feeding back Dennis had to step away for a meeting. So apologies. I'm going to be using his notes. And we took a little bit of liberty when it came to the question to, instead of adolescent girls and young women, we said just in general adolescents, not only girls. And I think on previous discussions as well, we also mentioned, it's very difficult. We keep talking about adolescents, but at some point we also have to acknowledge the fact that we are reaching them almost a little bit too late. So how do we reach pre-adolescence, which is opening up a whole can of worms, probably beyond the scope of this discussion. And, we can talk about it from a health systems perspective and DSD and Department of Education, but as a parent myself as well, how would I like people to be reaching out to my children when they're pre-adolescent and talking about sex? So we spent a lot of time around that, but and we might not have followed the questions exactly, but we also looked at what did we take from the presentations and what really stood out to us. So obviously I think for us a big thing was the condom use in South Africa, and especially amongst our adolescents. So this is a tool that's been used for over 40 years, and we don't want to throw out the baby with the bathwater, but we need to reinvent the way in which we message about condom use. We know that we've seen an increase in congenital syphilis. We know that other STIs are a big, big problem. So we still do need condoms. We definitely do, but are we using the same messaging that we were using 20 years ago? So how do we change that and make it more enticing? And how do we make sure that those condoms that we provide don't end up in the landfills or being rubbed on people's joints to help their arthritis, but rather be used for the appropriate things, sex? And empowering young women and adolescents in general, we spoke a lot about, and I think we then jumped to U equals U. We all agreed together there needs to be a more leadership from Department of Health and Provincial Health and from healthcare workers in leading this U equals U campaign, direction, and to get the momentum going. U equals U has been around for a very long time, and we've had the scientific evidence for a very long time, but the messaging really needs to come clearly through that it's a campaign, but it's also a strategy. So there needs to be some strategic thought about how to ensure that the correct messaging for U equals U goes out. And condoms lines up with U equals U. How does PrEP line up with U equals U? And I think that was one of the big things, is that we need to encourage the momentum, or get the momentum going, for South Africa to accept and take it forward. And hopefully the Western Cape will be the province that actually takes the lead on this. And then we spoke about good role models, which was, we all know that peer-to-peer support does help. We've had excellent programs in the past, like Mentor Mothers or Mothers to Mothers, and we now currently have youth ambassadors. And we know that this is an excellent intervention, but we also need to make sure that they are empowered and they are equipped with the skills to help influence an entire community, because that's one-on-one, but how do we create a behavior change within a community using these peers and role models, making sure that it's the right role models. Anything else that I might have missed? And again, apologies, Dennis was going to give this feedback, so anything else I missed? Okay, wait. And his writing is really bad. But don't tell him I told you that. Thanks, Joe. Oh, wait, maybe I did miss something.
Oh, yes, and we also mentioned that in some of the interventions, we need to work collaboratively as departments, not only focusing on the Department of Health, but different departments coming together with interventions. Say maybe we are talking about condom use. It's not only the responsibility of the Department of Health, but also Social Development and Department of Education, making sure that children are aware of the importance of taking care of themselves. And also going back to the messages of abstinence. We used to talk about them, but we are no longer talking about them. And we made also example that what is it that we are doing as South Africa that countries like Uganda, countries like Botswana are doing differently when it comes to the messaging of U equals to U. So one of the things that our colleague mentioned was that there is constant communication with regard to U equals to U. The message is not only for people living with HIV, but for the community at large. When I'm saying the community at large, it's you and I, it's the Department of Social Development, the Department of Basic Education, whereby everybody is taking ownership that if I'm living right, if I'm focusing on one partner, if I'm using a condom, then we are able to fight the HIV on its own. So the responsibility is for everyone to take ownership to say, we want to fight HIV, and constant communication, people to know and understand that HIV is there, we need to take care of ourselves. TB is there, we need to take care of ourselves. So this is one of the things that we mentioned. I'm not sure if I'm leaving anything. Oh, I'm Teboho Sifufula, the PEFA Provincial Liaison for Western Cape.
Oh, sorry. Hi, I'm Erin. I'm from Kailicha Eastern Substructure, Medical Officer.
Questions for clarity. Our spokesperson, Dr. Ibrahim.
Good afternoon, everyone. I'm Ibrahim Kriel. I'm Medical Officer, HAST, Southern and Western Substructure. Yeah, my handwriting is also very bad. So I'm going to try not to repeat what the other group has said because they covered quite a few of what we discussed. Our discussion took a bit of a tangent, but we came back. So we know where we need to reach young women and adolescents especially. I think the discussion we had is what do we need to communicate to them, and that's also quite difficult seeing that there are not many young people around the table. So I think that's one thing we need to do is engage the youth. Sorry, I'm not assuming your ages. And then I think the data showed that early sexual debut and having multiple partners doesn't lie with the women, it lies with the men. So I think it was raised by another group previously that we need to target the young men, and how do we get messages across so that behavioral change can happen there. And then the willingness for PrEP. I think that was also an eye-opener. And I think this is an indictment on us. I don't think we're doing well with PrEP, and we really need to look at how we can leverage from that willingness of these young people to use PrEP. How do we make it more accessible, more available, and more acceptable as a form of prevention? Because, as we mentioned earlier, U equals U. If my viral load is undetectable, I don't know what the next person or my partner is. So, but we'll get into that a bit later. In terms of condom use, just something to add on what you guys said was utilizing other services to promote condoms, because condoms, it's not just HIV, it's pregnancy, it's STIs, it's everything else. So how do we brand a condom? Because sometimes HIV, and it's historically has a negative connotation to it, and we're trying to change that, obviously. But in the meantime, how do we put positive connotations on other known interventions? So the availability of family planning and emergency contraception to prevent pregnancies, and then condoms as well. And then what is the message to a boy versus to a girl, a male and a female, in terms of condom use? Just looking for things that are different to what they've said. Blah, blah, blah. Oh, and we discussed around sex itself and how it is seen in society, especially amongst young adults and adolescents. Sex is often spoken about in a bad connotation. So having sex is not good because you will get HIV and you will fall pregnant. But it's happening. And how do we change that mindset in saying that it's can be a good thing if it's done safely? And I think Neelis went to the other extreme. To say it's good to have multiple partners, but it's just to give a positive connotation to it, because because it's happening, and we want to demystify a whole lot of these negative connotations. And then, why are children having sex? Besides it being fun, besides it, is it because of peer pressure? Is there the impact of substances, especially in certain communities? Is it boredom? Should we have a variety of other departments and sectors coming in to give other options to young adults and adolescents? And then we can't ignore the aspect of transactional sex. It's still happening. How do we empower our young women, especially, to protect themselves? Sometimes it's unavoidable. Transactional sex is unavoidable just for survival. But how do we utilize their willingness to use PrEP, the availability of family planning, and as I said, EC as well, emergency contraception. We spoke about gatekeepers in schools. We know that we have to. That's a place where we can get young adolescents and even young adults in schools and higher education institutions. But there are often gatekeepers, as Neela said. Sometimes the governing body, sometimes other parent groups, teachers, the principal themselves. So how do we overcome those hurdles? Getting to U equals U. As mentioned, there was a thing started in the Western Cape even before the national campaign. However, it is not as simple as we think it is, and I think we should start with our staff itself. So Department of Health and our staff, the partners and their staff, to make them comfortable in having that discussion, equipped to give the proper advice, and be comfortable in how you utilize U equals U and the advice you give. For a pregnant woman, if she is undetectable, then the baby will be born without HIV, and if you have partners, you can protect your partner, etc. And then we didn't speak much about the role models. I think we skipped question B. I think a few of us discussed briefly saying we must have HIV positive role models as well as HIV negative role models, because it's a reality, and often we focus on just prevention, but living with the disease is also a reality, and we need to also focus on that. Anything else that I've left out, colleagues? Yes? Covered. Thank you.
Thank you very much, Ibrahim. Now we open up any additions, any questions for clarification. Yes?
Hi. Sorry, we had a long discussion around it, but I think one of the things in the Western Cape is to understand the cascade a little bit better, because I think I'm really excited to look at the data where we see the second, 86% of people know it, 90% is actually on treatment, and 92% that cascade. I know then when we do it in reality and we do the percentage, then our gap looks so huge, and then we always feel a bit bad in the Western Cape because we have this huge gap of treatment. But I don't think this shows that we don't have that big gap. And I think that's really reassuring for us, because we've put so much effort in trying to get people back in treatment. That's the right thing. But I don't think we've done enough for the other things, because we're so obsessed to get people on treatment and keep people on treatment. So I get the feeling that we need to do more for prevention. We need to do more for maybe not just let testing go, because I think testing is a wonderful way of communicating with people and take things further. So I think that's my key message, that second 90 and the gap. We probably need to talk about that more to understand it better and to see where we fit in, because we've been clouded with retention and stuff.
Thank you so much. Any other comments from anyone else? I'll bring the mic to you.
I just wanted to note that for the past 20 years, we have been talking about abstinence in schools, but that has not been working. statistics is also showing us that it's not working. But if we engage in a conversation about safe sex and how to prevent yourself, and that there is actually methods out there to protect yourself, and I think that's the way to go. Because we can't be talking about the same thing for another 10 years. Thank you.
Thank you so much. Any other final thoughts before we move on to the third question? Are we all still together? Can we maybe just have an idea which groups dealt with the third question? So I'm standing right next to the groups. I'm in between the two groups. So just to remind everybody that this question dealt with what needs further strengthening in the province or district program. So your spokesperson.
Good afternoon, everyone. I'm Inika Lanen. I'm based in the Khayelitsha and Eastern Substructure Office in the Department of Health. And I'm speaking on behalf of Table 7, 8 and 9. We joined forces. So we had a robust discussion, but obviously we'll only be covering a little bit of it here. So for the first part, what needs further strengthening in the province or district program, Neelis actually just stole our thunder completely, because we said the second 95 and prevention. But as Neelis was saying, for the second 95, we need to interrogate the data a little bit more, because there does seem to be a difference between what our data is saying from what we capture routinely and the results of the survey, and it might be a definitional issue. But we are doing ongoing work in the province to clean up our own data and identify people who are genuinely disengaged from care and to get them back into care, and there's a lot of work being done on that. But on the prevention side, we were quite alarmed to see the declining performance in terms of condom usage. And the discussion in our group circulated around, is this because our communication campaigns seem to have slowed down quite a bit when it comes to the use of condoms? It's not as prevalent as it was, or as present as it was in previous years. And perhaps we need to think strategically about where we're placing our condom dispensers. Should we be more creative? They shouldn't just be in our health facilities, but in places where people gather recreationally as well. And this requires partnerships beyond the health sector, but also the Department of Education and social development and other areas, and civil society partners. And we also need to be thinking about using new platforms for communication that weren't as strong in the past, such as social media, which can be a very powerful tool. Then on the more specific questions, reflecting on a VMMC program, in some sub-districts this seems to be quite successful. For example, in Mitchell's Plain, they're actually exceeding their targets for 10 to 14-year-olds, where the demand is actually exceeding capacity. But in other areas, the demand is quite low, and for other age groups. And something that seems to work is to have community ambassadors generating demand for the service. But some of the barriers are the access to the service. The hours are not convenient. It's only at certain times and days in the week. And we don't communicate so well about when these services are available. And a big factor that's becoming more and more of a barrier is the lack of security in some of our areas, where we cannot offer these services because it's not safe for those offering services. Then moving on to the youth HIV prevention campaigns. We said again, as been said repeatedly by the other groups, that we need to collaborate better with the Department of Education and be looking at how can we target our messaging in broader campaigns at the youth, and link the other issues, health issues that we have with the HIV program. In the Western Cape, we have a specific issue with teenage pregnancy. And this is not a separate issue from HIV. The same activity is resulting in these the two different conditions that we want to prevent people from getting HIV. We want to prevent teenage pregnancies. And we seem to be lacking mass communication aimed at the youth that is effective at reaching them. Then finally, the prevention strategies for men. We didn't have too much time to discuss this, but as is well known, we feel the health service is quite female-focused. But we were pleasantly surprised to see that actually a high proportion of men living with HIV are on ART. And perhaps there are lessons to be learned there, and we need to look a bit closer at that interesting fact. And so just to sum up some key points, essentially we thought we've done quite badly in sustaining HIV prevention campaigns in terms of our communication strategy, and we're not collaborating enough between departments and with civil society partners to use our limited resources for maximum effect. And we need to re-energize HIV prevention campaigns using new channels that will reach the youth. Thank you. Thank you very much. We will move to table 3.
Hi, everybody. Stand up. My name's Caroline. I work for City Health, HAST unit. I'm a medical officer. I think a lot of the things that I'm going to say have been touched on by all the tables earlier, because I think I'm the last person to go, am I? Right, so let's see. With regards to VMMC, what has been the result of voluntary medical male circumcision programs? So we saw the data that there was a reduction from 52% to 50% in the Western Cape from 2017 to 2022. We were wondering if COVID-19 could have potentially had an impact there, that perhaps there were less services offered during the pandemic. There's obviously cultural aspects to be considered with traditional circumcision being preferred, or male medical circumcision not wanting to be, that people might not even want to discuss male medical circumcision. We spoke about the fact that some healthcare workers might not have, lack of awareness of where to refer patients to for male medical circumcisions. An example of having worked in a hospital where male medical circumcision was being offered, but the healthcare workers weren't aware of that. The issue of female, there are way more female healthcare workers, and clients don't feel comfortable speaking to female healthcare workers about male medical circumcision, so that could impact. Moving on to the youth campaigns, if they were successful at reaching target audiences, and the data shows that it hasn't. So there's been an increase, condom usage is down, we're not doing so well at offering PrEP. So we also spoke about engaging with schools and how to ensure that the services we offer are more accessible or easier, more accessible to clients, so making sure that services are available after schools for students to access them. We spoke about modes of communication and making sure that we tailor-make, have different modes of communication to reach the youth. Last question was around HIV prevention for men. Have they been successful? Have HIV prevention strategies been successful for men? And we said no, so not as successful as it should be. We are definitely struggling with testing. We need to improve our testing for men. We know that it is more females that come to our facilities for family planning, bank, and it's really only men who come in when they are unwell or injured. So how do we reach them? We did have a discussion about secondary distribution, so using our female clients to reach the men out in the community. We spoke about the drop in condom use, and that is obviously important for men, and the focus on PrEP having been more on women, and that needs to change, and we need to be looking at men as well.
So what we spoke about in this table was around male services. We have been prioritizing young girls and women as if we are not in the space where we have young boys and men. So what we spoke about was we need to find a way not to shift the focus but to balance the engagement that we are making with young boys and men to speak to the HIV prevention messaging, and also for men to see themselves as part of a protective structure in the space, so that we also talk to gender-based violence issues. But also, we're also acknowledging the services that are already there for men, particularly the men's clinic, MENA initiatives, and different programs. But what we're saying is there's a big gap in terms of that we need to relook at. The issue around condom usage and the power that condoms gives to men is a big challenge, because if men do not want to use the condom, then we struggle in the house. So we are saying, when we started to talk about PrEP, we prioritize young girls. And now we see that the HIV is not going anywhere. And as much as there's a decrease, but when we look out there in the communities, there's a big challenge. Just to tap on the MMC. Interesting conversation that we had around the aging, because young people engage in sex at an early age, and they get to be HIV infected with HIV at an early age, but they circumcised after 18 years, which is an interesting conversation that men's sector and everyone who's providing services to men need to look at. How do we then engage the structures that are talking to circumcision to say, let's find a way and engage with the initiation program to say, how about we do it at the same age where they are starting to engage to sex, because we're saying the circumcision contribute to HIV prevention. So we need to balance that. And we also acknowledge the cultures. A good thing is in this table, we also have Xhosa culture that seem to be, that language about the circumcision. But we're saying, let's find a way, let's engage and see what we can do within the circumcision, and learning from the evidence that was presented to us that young boys do get HIV before they get circumcised. So what do we do about that?
Yes. Yeah. Yes. I think as well, I mean, several times it's come up in terms of the campaigns and prevention campaigns as well as the education campaigns. But I think an opportunity lies for us where we do better in measuring the impact of these and the input of these campaigns. Because if we're going to move into TikTok, Facebook, or whatever social media campaigns, we should be able to say this is the impact of this and this is how it's affecting the particular population. And I don't think that we are even shifting our thinking into that space to see how best then can we kind of quantify the impact of these campaigns in terms of what we want to accomplish.
For a minute, I thought AI was listening in. Okay, colleagues, so now we open the floor. Any additions? Any points of clarity from anyone in the room? Can we get the mic to Joe?
Thanks, colleagues, and congratulations to the HSRC. We've been long awaiting this research findings, and it's great to have the kind of best data to be able to have these great conversations. I think my question is around what we know about youth and really looking at ourselves in the mirror. And by saying ourselves, well, my name is Joe, I'm from USAID, but thinking about ourselves as institutions that employ what I would imagine to be thousands of youth within the Department of Health, with your 24,000 or so healthcare workers in the province. And then for folks like Prof and Neelis, who employ hundreds of healthcare workers, or so, you must have tons of youth. And yet we kind of talk about youth like this concept. and it kind of reminds me, like, why don't we just ask the youth that have been trained in health, that know the services that we provide, that are familiar with our context, to see if they're able to design new interventions for youth. But we have youth, you know? And I think about ANOVA's prep work. ANOVA, you know, led by your prevention team, pulled together PrEP ambassadors. So these are younger women to be able to conduct outreach for PrEP in facilities. But they also were tremendously successful in convincing young boys and men to also start on PrEP. So I don't think we can assume that a man must talk to a man. I think just a person with the skills to talk to men, to make men feel comfortable, can actually be successful at kind of generating demand for services. But my question is, like, do we have youth committees, either within the DOH or even among the teachers at the Department of Education, that help to create venues for designing youth-centered programs? And to our NPO colleagues, like, is there a venue to listen to the youth that we employ in order to design programs? Because we might be missing an opportunity for tackling some of these questions if we continue to see the youth as outside of us.
Thank you, Joe. So I think the question, Neelis, I see you burning. The question is really, you know, what are the spaces, what are the opportunities that exist to engage youth? Our own youth, yeah. So I don't know if our colleague is still here from education, not to put anyone on the spot, but if there's any contributions. Yeah, okay. I know there's programs like peer groups, you know, so there would probably be many opportunities, and it's an area that we can unpack. I note you, Tebogo. Let me go to Neelis. I can see he's burning.
I need to respond to Joe because we always respond to each other. But anyway, I think, Joe, I hear what you're saying. I think the problem is bigger, is that we are so focused on what's happening in clinics, and we're so focused on the medical stuff that we can do in clinics, that we don't actually create bigger discussions that improve, you know, even our own staff, that you think you're so busy training people and the complications of medication and those things. We don't really address, and we don't really know how to address all these social determinants of health, how to take your service and prevention into the communities, how to work with communities. I think the whole idea of moving away from developing services in a clinical to develop services for a node and the whole COPC things is the right direction to go. But how do we create platforms to discuss that further, that's useful, and that's, you know, that we as medical people feel it's not just talk, it's really do. Yeah, I agree with you once. Thanks.
Thank you, Joe. Let's go to Tebogo and then we go to Proferi.
Oh, yes. Joe reminded me there is a young, vibrant young lady. She's for civil society. I met her. She's from Limpopo, but she's civil society, Western Cape. I met her at the implementation meeting. She was addressing Mr. Murewana, PEPFA, and everybody, saying that there are so many messages, there are so many creative ways that we can do as youth. As much as we are able to use Mom Connect to remind our women to take medication, to do adherence, there are other ways that we can use you is equals to you amongst our teenagers using digital platforms, because most of our youth spend their time on the phone. And then she mentioned something that, you know, everybody just kept quiet, that there are other ways we don't like to use condom, but there is another message. There are other ways of having sex without having sex, but we are not talking about it. So these youth leaders can really change our Western Cape.
So I completely agree, Joe. We need to make the most of our youth who are employees. And I mean, we've intentionally, with our dreams funding is in KwaZulu-Natal and in our Tambo district in the Eastern Cape. But you know, we employ learner support agents who are placed in schools. So these are peers who speak to other learners, and then kind of recruit them into the programs, identify vulnerable youth, and then refer them into the program, which provides education and then and HIV prevention education, and then links to biomedical services. And then there are hubs of hope. So kind of like this node idea, Niels, I think that should be looked at in more detail and explored for implementation in the Western Cape, to have a community-based, a hub of hope that draws youth with activities and intensified economic strengthening activities. Because people, you know, youth are hungry to learn and to be able to earn. And so, you know, those who, if we build skills and link the skills building with HIV prevention, education, and access to the biomedical services, it can be very powerful. And then having peer educators who are youth to link at the schools. So that kind of hub between schools, the clinic, and the community is really, really crucial. And we do, because we employ, these are the people who are communicating, the youth are communicating with each other, and they definitely give feedback into the program about the messaging. There are WhatsApp platforms for them to communicate as well, and also a loyalty card, which gets airtime incentives. So I think there's a lot of creative ways that we could do more with youth in this province. Thanks.
Thank you so much, Harry. So, colleagues, let's move to the fourth question. Can you spot which group didn't have a turn yet? I'm just seeing whether we all, did we cover all the groups? So, yeah, so question number 4, I heard earlier, I was trying to listen actively, I think, was it this group that said that they actually ventured, one of the groups said they ventured into the other questions as well. Was that right? Did I hear that? So, I don't want to put anyone on the spot. So I'm going to just take a 360 and ask anyone in this group if you would like to feedback on question number 4, or just some of the thoughts. Because I'm sure I heard somebody say it, yes. And then we all add to the story.
This is karma, because I'm notorious for just calling on people. Changing patterns of prevalence among adolescent girls and young women. And this also relates to B, how do we better coordinate efforts on health intervention strategies at local levels in South Africa? So we did talk about improving that, that referral pattern and network between education and health, and utilizing schools as a channel for communications, but that channel for communications should generate demand and then be received by a service that's ready to serve youth. What we've seen in City of Cape Town is that while the comprehensive sexuality education interventions are almost everywhere, however, getting principals, parents to sign consent forms, all of the other, I believe we call them gatekeepers for the education channel, are quite overwhelming to be able to then deliver mobile health services in front of schools. So I do think that we need some pretty high-level leadership to cascade that type of guidance down to be able to unlock the use of schools as channels for health services and meet those common goals. And hopefully maybe that could be something that's raised in such venues like the PCAT venue, because it is cross-sectoral. I think being able to have a united message around U equals U is going to be needed. Like, is the school health nurse aware and able to communicate U equals U? Is the community-based services healthcare worker able to communicate U equals U? I think we think about U equals U and we assume it's a HAST medical officer, but really for the campaign to proliferate, it needs to be a whole intersectoral group of people that are singing from the same songbook and doing it in a way that just as well as John Blandford did at the very beginning. Like, it needs an army of people saying what the science is and feeling comfortable standing on the shoulders of the scientists. How is HIV testing and status awareness, ART and viral suppression seen in your community? I mean, I think within the control program, it's become our language and our lingo. I do think that the data is showing us that there might be pockets of population that might have lost in translation, like particularly if we're seeing low testing rates among young men. I think our advantage, and it was mentioned at the top, is that a U equals U message is also useful for significantly increasing testing rates, especially among young men. I believe the Desmond Tutu Health Foundation research showed that cohort that received a U equals U message had 9 percentage points higher rates of testing as compared to those that did not receive a U equals U message, or possibly higher. So I think we have so many tools, but we might not just be applying them as systematically and as consistently as we should.
Thanks, Joe, for that comment, especially in schools. And then I'm thinking about it that for youth in schools, yes, you'll find a lot of them, about 67%, but there is youth, 33.5% that are unemployed, that we still will not find in schools. So I think it's high time we also learn lessons beyond Department of Health. So I'm just, as I was sitting here, I was just thinking, I don't know whether any one of you know the shoes called Crocs. Yeah. So Crocs, they were not doing well, and it was about to close the business. And what they did, no one was buying them. To me, they look ugly anyway. So no one was buying them. And what they did, they literally, with youth accessing social media, I'm thinking those unemployed ones exactly, because they've got time for social media. So what they did, they got an influencer. You know about influencers. The influencer, they gave Crocs different colors and what have you, and you know, most they even now have messages to an influencer. And now, if you look around and see, everyone, youth now is wearing Crocs. I mean, the cheap ones, the real ones, I was just made to buy a 1,500 pair of Crocs, you know, those ones with thick for a youth person. So, but what they did, they used an influencer to actually advertise for them. It's all over now, they are making bucks. So now I'm bringing back that to us as Department of Health. Could we not fork out, or maybe PEPFAR, fork out a few bucks, and then we get one known influencer to actually send out this messaging of U is equal to U, and then we quantify somehow and see.
I must say I appreciate the richness of the discussion in the room. So
hello everybody. So I think from my side, when I was looking at some of the results, and I was always looking at the other provinces as well, because obviously we need to compare ourselves against others. And I always wonder, what is KwaZulu-Natal doing differently? And besides us, you know, working intersectorally with our own departments, we also need to speak to other provinces. You know, look at their best practices, because we are not big enough, you know, to say we know it all. We need to ask them, because, I mean, KwaZulu-Natal is, their villages, their landscape is different. And I think, Harry, you are working in KZN and you are familiar with what it looks like, but we should be tapping into what others are doing. And not just focus on what we are doing, because clearly we are putting in so much effort and yet we are not yielding the results we want to see. So, but yeah, look at others as well. Thanks.
I love it.
For me, to probably to latch on you, Karin. My question has always been, I mean, Western Cape has remained with the lowest prevalence in the country right through the ages. And yet when we look at data like this and we look at the key drivers, we're always the worst performers, or made to feel that we're the worst performers. What is it that we are missing? Because somewhere, somehow, in spite of us performing badly in terms of key drivers, sometimes the 95 reflects us as being the worst, and yet we've maintained a low prevalence. So somewhere there's something we're missing in this communication of the data.
As you're coming. While we're having the conversation on this table, we also look at the prevalence decreasing and PrEP uptake being very low at 1%. And we're trying to look at what might be working that we are not seeing, as he's saying that we've been low with our own problems. Maybe a question is what contribute to the prevention if PrEP is low and condom use is low? Would we then say U is equal to U is the key message that is keeping the HIV prevention as where it is now, or what else that we need to look at so that we can advance and keep that where it is, while we're also talking about PrEP messaging and how do we improve the uptake of PrEP?
I was about to ask whether we have researchers in the room, because I think the colleagues are also raising potential questions that could be further investigated for us to have that deeper layer of understanding, specifically the drivers, as you were mentioning. And I think there's definitely a role for research also for us to have a better understanding. Can I just check around the room? Niels?
Hilary, maybe not research, but I think more than ever before, it's so important. I think you use the words aging, and maybe it's the people aging, but also how the epidemic is aging, is that we're actually handling a lot of different epidemics in different communities. And if we're not going to have customized response to how the epidemic is playing out in a Gugulethu, it's different to how it plays out in the Noon, and how it plays out in the southern, and Grassy Park is also different. And I don't think we do enough to really understand what's the difference. We're so busy trying to get to the 95 for the whole city and all the province that we're actually missing what we can do for every small place what we do. So I think a few years ago there was a lot about know your epidemic, know your response. I think that's more important than ever before. And yes, the researchers can help us, but I think it's a responsibility for every node or clinic or group of clinics to work out a response that works for that area using this data, but also the knowledge of people around there and the knowledge of the youth. Thanks.
Thank you. Thank you, colleagues. I think I see some more hands. So we actually have unpacked quite a bit as a collective. We started reflecting on question number 4, and as we're rounding up, would encourage colleagues, if you've got any final thoughts, to share that with us before we will go into the reflections. We're still doing good for time.
Thank you. I just wanted to speak to the last two comments. So I think this has been very enriching, first of all. But I want to say that what we presented today is just a snippet of the data that we have. The deeper questions are going to come. So we've got this data set is very rich that we're going to be able to unpack and answer some of these questions that you are saying. For example, one reflection was that there seems to be a mismatch in what the data is showing us for the Western Cape. Understanding the drivers a bit more. So as the Western Cape report comes, it will be more detailed in terms of looking at that data and understanding what it means. And also you can take a historical look at what we've also analyzed in detail, for example, from the 2017 survey to understand what was happening then and what is happening now. However, I also want to say that, as has been said, that we need to look at what is happening in our local context. You know, the research or surveys like this will not answer everything. So it gives you a teaser, if I may say, just alerts you to what you should be looking at. And so the work that then remains is that as healthcare providers, as partners, how do we then take this data and use it, exactly as you were saying, to understand a bit more what is happening in my context to then address what needs to happen. So we think that the study has done its job because the questions that are being asked are pertinent, and this particular meeting is very important because those are the type of things that we need to hear and to take forward. And finally, maybe the other thing is that some of these questions that are being raised are to say, when we go forward, how else can we serve the province better? Maybe ask these questions in a different way to address these issues that we've had today. Thank you.
Thank you very much. Colleagues, so I'm just checking whether there are any final contributions before we will go to the next item on the agenda, which is the reflections from myself and from Nicolette. Any final burning inputs? Are we all still together? Okay, so I just want to check whether the slides are up.
So thank you very much, and thank you to all the groups for your rich inputs. So every time we gather like this, I always get the sense that we don't have enough opportunities to really engage and have these types of discussions. And there's always such a lot of rich information that comes out of gathering a diverse group such as we are today. So maybe just from the group feedback, some of the emerging themes that we are picking up that I think most of the groups touched on is really the need to expand HIV self-screening, particularly to increase HIV testing amongst men. We hear the call for improved messaging around the U=U campaign and creative content creation for social media platforms. To strengthen condom distribution and to make condoms more accessible, especially for young people. Somebody said we need to reinvent how we market and promote the multiple benefits of condom use to ensure increased usage, because condoms offers more than just protection against HIV, it offers protections against other STIs, is also a contraceptive method. We need to improve our intersectoral collaboration between government departments, and there was a lot of talk around how we improve collaboration between the Departments of Health and Wellness and the Education Department to enhance our school-based programs, to increase the reach to young people of all genders. But there's also collaboration work with other departments such as social development, economic development and tourism, for example. So we need to look broader than just the social cluster as well. That the focus on adolescence must extend to the boy child and young men. So the behavioral drivers amongst the young men are particularly concerning, especially around the age of sexual debut and multiple sexual partners. And then we need to optimize our touch points and opportunities within the health system and beyond the health system to expand our access to HIV prevention interventions. So I'm going to hand over now to Hilary just to do some key reflections overall for what all the inputs we've received today.
Oh, I must go forward, no? Okay. All right. So I think before I go into some reflections overall, I would really like to first, say 2 words that mean a lot. And that is to say thank you. Thank you to Dr. Makola, the Prof, and the entire team of presenters from the HSRC. Also want to acknowledge and say thank you to all the partners that have contributed to make this a success. You all would have noted on the program that there's been multiple organizations involved in making this a success. And of course also, without the contributions from the community that participated, I know they were acknowledged in the presentation, but I think it's also quite important just to say thank you to each and every one that have participated in providing, their inputs so that one can have a richer picture. Of course, to all the participants, and I want to start with the participants online. I'm actually not sure how many participants are currently online, but I would like to start by also acknowledging and saying thank you to all the participants that stayed online, those that kept on engaging with the information, listening to all the feedback in the room. And then, of course, also saying thank you to all the participants in the room. Thank you to all of you. And then also, as part of the thank you, to say thank you to those people that were outside this morning, that were registering all of us, and all the administrative staff involved in making sure that this bus was moving forward throughout the day. So then I would like to just go into giving some reflections by saying, as I've gone through the thank yous that I think we have in this feedback or dialogue session, have really had some inclusive representation. Maybe we are still missing some voices, but as far as I know, this is also the first time that the provincial dialogue extended beyond a more higher level provincial office, but that it was also the first time moving towards a more inclusive audience in providing the feedback, and at the same time using it as an opportunity to dialogue. And in that way, it really brought together different perspectives, different strengths, and different expertise into the space. And for me, it connected so well with the questions that we were asked this morning, the questions around the expectations. If you can still remember the word cloud that was up in terms of the expectations. And then there was also some input around the image gallery. And then there was the question around the uniqueness. We had a lot of laughter in the room, but I think part of the uniqueness is the fact that we are bringing different strengths when we come and we join and share the table. So I think the expectations raised at the start of the day for me, I think it also just highlights the need for further interrogation and information that we need to look at a more deeper reflection looking at the information that was shared, and I think some of that will be shared at a later stage when we receive the report. I think Dr. John reminded us this morning also in his opening remarks, he said that this is really the beginning of a broader conversation. So, you know, and in terms of how do we then use the findings to inform the HIV response in the province, I think throughout the day we reminded each other that context matters and that the landscape doesn't stay the same. As we were reminded with the history of the surveys over many years, the landscape has changed. But similarly, the landscape in communities are also changing. I think with the intention early this morning already to cascade the information, you know, to a group, there would be a need to take this information and, as I want to put it, to break it down in digestible chunks, to make it easy when we engage, and when we engage different stakeholders across platforms, in facilities, within health, within education, broader than government departments, in civil society as large. And I think Prof at the back reminded us also that the findings gives us a glimpse, but there are actually more that we can expect. But I think it also opens up to what is happening at a household level. So it's opening that window so that we can have a better view of what's happening at a household level. I think overall we could see that there's improvements on most of the indicators, but there's definitely areas that require attention. I think a lot of that richness came out in the group discussions as well, in the dialogues that took place within the group. And then just to say that we need to keep on working collaboratively. So the colleagues within the Department of Health and Wellness, and I think also most of our partners are aware that we use the CALM agenda as what we put forward for our collaborative work. And basically what CALM stands for is connecting. And today was also a form of connecting across sectors. I think the importance of connecting came out also as a strategy that we need to work on as we move forward. Then, of course, the A in the CALM is for aligning to the strategic vision, because in the end of the day, we are all in the same business of wanting to make sure that we move towards achieving the goals that set out in the NSP as well as in our own provincial implementation plans. And then in terms of the L in the CALM, the learning, a lot of what happened today is part of that learning, you know, where we use the data to learn from before we actually get to the M, which is the making and the doing. Because I think from today, it's also clear that as we continue to make and do, that there's things that we probably need to do differently. So it really fits perfectly what we've done today within our common agenda in terms of working collaboratively together. So I know it's a lot said, and thank you to Nikki for providing us with the inputs also in terms of the key themes that we can take forward and have deeper conversations moving forward. And we do look forward to, you know, receive the full report and keep on collaborating with you in terms of filtering through the information, having a deeper understanding, and also then be able to translate the information in a form that it can be used at different platforms. So thank you very much, colleagues. I'm going to hand over to Dr. Makola for the final words.
No, thank you so much, Dr. Hilary, and the colleagues for the rich discussions. It has been really a wonderful day, but a lot of work that lies ahead, even in terms of what we look at with the data. So before we actually go, I'm going to ask Mr. Adlai Davis to do a closure for us, and while he's coming forth, you can just scan this. Remember, we spoke about an evaluation of the day so that we look at what we can strengthen, looking into how we can have these conversations again later on through other projects, or it can even be after 3 years when we've conducted the other survey. But as the province mentions, we'll try our best to also be part of, you can invite us to come to research forums, to discussions that we also then dig deeper into the data that we have. Obviously, there are other research that are somehow connected to this that we also do. For instance, the barrier study that looks at people that have challenges with adhering to art. There's also the stigma index that we are also now preparing to conduct amongst people that are living with HIV. So there's a lot of work that we do, but it would be nice that we're able to feedback. Sometimes we don't have the funds to do it this way, but even in small groups that we interact, for also us to understand how we translate that information in a more understandable manner for users of such information. So colleagues, if you can just scan and then you provide feedback while Mr. Davids also just provides a closure. I think we are on track in terms of time. And again, just thank you, Dr. Hilary, for really running the program quite well. I won't speak after Mr. Adler, so as you leave, note that there are snacks just outside, so if you can just grab something, and it's something that as you think about, reflect more about this, you'll be reflecting while snacking on something as well.
Yeah, what is left for me is to just say thank you very much, and Dr. Makola, for your leadership as well, not only for today, but the 8th of the 9th dialogue. So well done to you. And Dr. Goeieman, thank you so much for co-facilitating, keeping us in check and pulling us in the right direction. What's left for me is to echo some of the points that were raised, and also Ms. van der Walt and Dr. Goeieman for your the lead up to this, the high level meeting, and putting it into place, because we thought that was very, very important for us, so we don't dump everything here without, and that's great, and the cooperation we had, it shows. So thank you so much for that. I want to thank all the attendees. Coming into the city of Cape Town, I think it's a dreading thing coming into the CBD. But we thank you for braving it, and also to our online audience. We are very, very happy and thankful for their participation. The word collaboration was mentioned as well, and I think it's important for us going forward, because we know that when we conduct these surveys, how important it is for us to get buy-in from the local levels especially. There's no point we speak only at the national and provincial levels. Going local is very important for us, and I really, really appreciate the fact that there are people at substructures who are also represented here, so they know what's going on, so we can demystify what our work in SABSSM is all about. Just to remind everybody that's attending and online that we are working on a report which will be shared towards the end of this year, as well as more immediate term would be the presentation that will be shared to everybody, so that you can reflect back on that. Then for those who have affiliations with universities and those who are involved in research for yourselves, all this data that we have is curated by the HSRC, and we encourage people to actually use it for research purposes. There's a lot of longitudinal data available. So for further analysis, so please do contact us in the HSRC if you want access, or you know of people who are looking for research subjects in the field. So please do contact us. We speak about online and in person, but we want to especially thank our audiovisual team right at the back, who's keeping us with differential bandwidth and keeping us going both on multiple platforms. So we thank you very much, colleagues at the back, for your work. And then also our internal media, who is helping to keep the media fires burning, so to say, keeping us all engaged and keeping us talking about this work, as well as the media representatives that's still in the room that attended in the morning and listened to our to get for their presence and to report. And then, of course, to our admin team, they have been mentioned, but who's been working and spending literally sleepless nights and looking as bright-eyed and bushy-tailed every morning and setting us up. So to all the admin team, thank you so much for all the work you have done for us. It did not go unnoticed. Then, of course, we've been encouraged and more than encouraged by PEPFAR through CDC. We are very, very thankful for their funding and the encouragement for us to do this dialogues. It's a different for us in the game, instead of to go to the provinces and speak to people who are involved in implementation, who can really give us some really good insight into the work that we are doing. So we really, really appreciate the funding we got from PEPFAR through the CDC. Ladies and gentlemen and colleagues, thank you so much for your participation. We got some really rich information. We got some really nice debates. And for that, we thank you very, very much and travel safely home. Thank you.